From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
I'm Jennifer Abbasi for JAMA Medical News. Today we're talking about a big problem in clinical medicine, health misinformation. My guest is Dr. Brian Southwell. Dr. Southwell is a communication science expert at the independent nonprofit research institute RTI International and an editor of the 2018 book Misinformation and Mass Audience. He's also a scholar with the Duke University School of Medicine and its Social Science Research Institute, where he's spearheading training for clinicians on how to deal with patients who come in with health misinformation. Dr. Southwell, thanks for joining me.
Great. It's really a pleasure to be here, Jen.
So, health misinformation has probably always existed. Before our call, I spoke with a primary care physician, and she said that patients still come in with magazine articles and books with misleading information, and of course, people get incorrect health advice from their friends and family. But how has health misinformation evolved with the internet and now in the era of social media?
Yeah, that's a really important consideration because in a lot of ways, misinformation has been with us for a very long time. Many of us have a sense of snake oil salesmen, for example, and that was rooted in a real example, historically. And so false and deceptive advertising in the medical arena has been around for a long time, as has been problematic information that you might get from a relative or other things you might hear about interpersonally. In the current moment, though, we're faced with this situation in which there's a dizzying array of information that's available to you very quickly. You pick up your mobile phone, you hop on the internet, and you can find a lot in a hurry. And it's also the case that when you are faced with that information, you see something that you're perhaps excited about or interested by, you can share it so much more quickly than has ever been the case before. And so we worry about not only people's exposure to information, but also the diffusion of that information and misinformation in all sorts of ways. And so what I like about how you framed that initially, though, is there's a lot that we can learn from the past in terms of how people have engaged with misinformation historically that's going to be helpful, but we also need to think about some of the challenges of the moment.
How have we seen misinformation change since social media emerged?
Right. So one of the interesting aspects of social media is we might think about it in terms of a sort of flattening of the landscape in which it's difficult to tell and to trace the lineage or authorship of information in some ways. You might have legitimate information alongside information that might be much more problematic. And so that's something that we might worry about, is the sense in which there's sort of an equalized platform, and that may well give people the impression that all information is equivalent in terms of how useful it is or credible it is. Also, I think it's important as we think about misinformation to realize that it's not just one thing. It's not monolithic, that there's a wide range of it. It's long been the case that people have been able to encounter problematic information that's erroneous or inaccurate in different ways. But now it's also the case that you've got some people and organizations actively seeding the internet with misinformation. And so misinformation itself might cover the whole range of noise that we might think about, but some of the misinformation people are encountering has really problematic or nefarious authorship. It's also the case that misinformation varies in terms of how problematic it is. You might find something on some dark corner of the internet that really doesn't have much consequence for you in terms of your personal health. You also, though, might find and read or hear about misinformation that could kill you. And that's something that we also need to worry and think about.
So it sounds like you're referring to the difference between misinformation and what some people call disinformation.
And it's a really important distinction, I think, from an ethical standpoint, because you might worry ethically in terms of those that are actively seeding disinformation, those that are actively trying to fool or to be problematic in terms of what they're disseminating. But from the standpoint of patients, from the standpoint of those that we're trying to serve, all of the noise we might worry about. And so it may not necessarily matter as much in terms of the authorship if you are actually trying to help walk alongside people and to help them make sense of what's out there, because we know that their processing systems that people carry around with them tend to not necessarily differentiate based on who originally crafted a message unless they're aware of that source. And so that's something we might think about.
What type of health misinformation tends to be common on social media?
So I think it's important to realize that people use social media not just in search of the truth per se, but also to connect with one another and to bond with one another. And so if we think about information and potentially misinformation in terms of its currency, it's not going to surprise you that some of what travels on social media is that which is sensational or that which seems to be directly linked to everyday life. And so relevance really matters here quite a bit. We know that misinformation, which seems to be related to one's own personal well-being or the well-being of their loved ones, not only gains attention, but it's also something more likely to be shared conceivably. Similarly, we might think about more abstract scientific information, perhaps as being viewed as being more distant from people's everyday life and perhaps less likely to be shared. And so there's a little bit of an imbalance there. Right. And so if you think about an almost inherent advantage that many folks that are putting together misinformation might have, it's easier to craft something that's sensational or relevant if you have the ability to just put together whatever you'd like without necessarily worrying about it being true. Whereas folks that are operating from the standpoint of science and medicine often are thinking about the rules of peer-reviewed journals. They're thinking about the careful caveats that often accompany information. They're thinking about the abstract information that is necessary sometimes in writing up ideas for scientific journals. And so there is a little bit of a format imbalance almost that you might think about in terms of misinformation as it tends to get shared and spread and typical peer-reviewed scientific information.
It's a real challenge.
Mm-hmm.
Why are we vulnerable to believing health misinformation, especially during COVID-19? And what do these beliefs say about us?
Yeah, it's such an excellent question, Jen. And I really appreciate you thinking about our vulnerability in terms of something that we all share. Because as human beings, we are operating with human brains that have developed over time, but that tend to take in information in particular ways that we don't necessarily always pay close attention to. So there's a longstanding debate in psychology that's sort of neatly summarized by some of the contentions that were raised by a former philosopher by the name of Spinoza and another by the name of Descartes. And the sort of nutshell argument has to do with what happens when people encounter false information. Descartes essentially thought that people could know it when they saw it, kind of screen out false information. Spinoza had a subtly different argument and suggested that actually what happens is that we take in all information and then we make sense of it a little bit later. And that slight hesitancy, that sequence between taking in information and accepting it and then later tagging it as being false or true makes all the difference, because that's enough time to potentially share something on social media. That's perhaps enough time to forget to bother to critically engage or to not necessarily have the capacity to critically engage information further. And so you carry that with you. And so on some level, we're all vulnerable to sensational or other types of misinformation when we encounter it, at least for a moment. And so the question is, what can we do to encourage people to take that extra moment to critically evaluate what they're seeing? And generally speaking, to get people in a better spot in terms of critical engagement with their information environment. And so I think that's really important. Now, what people's acceptance of misinformation also says about them, I think, which is the other part of your question, is that we are human beings that have particular needs, and those are almost universal in a lot of ways. You think about the need that we have to be social and to connect with other people, the need that we have for hope for the future, the need that we have for basic safety and security and health and well-being. And what's interesting when you look at patterns of misinformation acceptance is that people are finding information that offers those things. And sometimes it turns out to be false or inaccurate. But nonetheless, if a piece of misinformation is framed in a way that offers you hope for the future, well, it makes sense that that would be something that you'd attend to. If misinformation is framed in a way that got one of your colleagues excited or a friend or family member and they shared it with you, again, it's sometimes important to connect with people, and that sometimes overrides our other critical judgment. So in a lot of ways, you might view people's acceptance of misinformation as partly a symptom of people trying to make sense of this crazy, chaotic world. Even in the case of conspiracy theories, I think there is at root there a hope that people have that somehow there is some explanation for the situation that otherwise is really viewed as problematic to them, that somehow there is some rationality to what otherwise seems like an open, uncertain future. And so I think that there's some attraction sometimes in misinformation that is succinctly and neatly offered to offer that kind of hope that people are looking for, that kind of explanation about the world. And I think that's a fair way to characterize some of the misinformation that tends to spread.
Can you contextualize that for COVID-19? So does this potentially explain why some people would rather believe that the pandemic is a hoax or is something that doesn't need to be taken that seriously?
I think what's been fascinating is, we've been thinking about misinformation for a while, but so much of this has come to a head here during this pandemic that we're all struggling through. And I do think that you're exactly right, that there is something about the types of misinformation that people are holding on to that offers them, some encouragement. It's easier perhaps to believe that we aren't actually facing this global pandemic. So at least initially, I think that may explain part of the reason why people would, turn to those types of conspiracy theories, for example. Similarly, people are looking for a relatively convenient and easy way to address what is a really threatening problem. There has been some more dramatic misinformation that's been spread, but some of it's been relatively mundane. There are recommendations to drink a lot of water as a way to protect yourself or pass the virus, which we know don't seem to hold up. And I think that's been important to note, not just because that information is false or inaccurate, but because it somehow was offering some kind of explanation to somebody or is offering them a concrete action that they might take. And I think that turns out to be really important for people in what's frankly a scary time. Even people that are holding on to information that seems to deny the larger contours of the pandemic, probably underneath that, on some level, are feeling some degree of uncertainty or fear that they're trying to somehow ameliorate with the false information.
Okay, I want to talk about the clinician training you developed at Duke. So what inspired it and what evidence did you draw from and what are the basic principles?
So over at Duke University, I've had the great and good fortune to connect with a number of colleagues in the medical school who have been worried and concerned about misinformation for a number of years. A few years ago, I had opportunities, for example, to connect with Rob Califf when he was at Duke, the former FDA commissioner. And Rob has worried about medical misinformation and its potential effects on society for a long time. And so in that context, the question then becomes, well, what can we do about all of this? And one of the I think, important answers that came out of many of those conversations is that actually clinicians themselves may well be part of the solution and, frankly, occasionally are part of the problem as well. And I'll explain what I mean by that. So something that we've found is that many clinicians have had the frustrating experience of their patients wanting to point to misinformation that they found online or that they've heard from somebody else. And in fact, actually, earlier this year, along with my colleague Jamie Wood, we did a survey with the North Carolina Medical Board of a couple thousand licensed medical professionals in North Carolina. And we found that actually more than 90% of them reported the situation of having encountered a patient that was believing misinformation, who had brought it into the examination room essentially to talk about it. And at the same time, we also found that only a small minority of those same respondents, less than 20%, had ever really been trained in any kind of way to deal with that situation. Mm-hmm. So you've got this pressing concern, and yet most people don't know exactly what to do about that. So the question was, could we come up with some ideas, some guidelines? And what we did is developed a workshop that really emphasizes a few different themes. The first is something that we've just been talking about, which is this perhaps non-obvious realization that actually we need to think about patient psychology a little bit differently. Maybe not focus right away on just how wrong somebody is in terms of bringing in a piece of misinformation, but first to realize that actually we're all in this boat together, that we all are vulnerable to misinformation. And so I think that leads towards a stance of greater empathy and compassion than sometimes is the case. It's also the case that those kind of conversations, frankly, are just awkward and difficult. And so part of the guidance that we offer has to do with how to manage those challenging or difficult conversations. And so we offer advice, for example, in a very time-limited clinical encounter, to not waste your time, not spend time discrediting sources, and to not necessarily go into a heavily technical explanation as to why something is wrong. And importantly, not to shame the patient for being wrong. But instead, viewing it as an opportunity seems to be really crucial. So not only can that be done in terms of your own body language, you think about the openness and care that you might be expressing, not necessarily having arms folded, trying not to scowl at what somebody's saying, but also thinking about the questions that you're asking. So instead of grilling them on the technical points of what they've raised, at least having a short conversation about why what they raised is important to them, which might actually offer you some insight as to what values they're expressing. And then that offers a path to potentially point them towards credible information, asking them about their access to information sources that they might not have thought about. And I think that sort of basic idea of redirection, but also acknowledging what was perhaps really valid in what people were raising in terms of the values that they're bringing into that conversation, that seems to be really important. And importantly, that seems to really resonate. I'll admit, I'm not a clinician myself. And when we first started having these conversations, I was a little bit unsure as to what the reaction to that was going to be. There's potential for the advice that I just offered to sound kind of pedantic. And we've tried not to do that. We've also been really pleasantly surprised that people have found this to be useful. Clinicians are so busy, overwhelmed, trying to do the best thing for their patients. And so pointing out some of these simple ideas has been useful. I also want to point out, though, and this is the third part of the workshop that we emphasize, this isn't the job of any one clinician themselves to do alone. There are individual conversations and opportunities that they have, but it also is an opportunity for our healthcare organizations to think about different roles that they could develop and different opportunities that they might have. And one of those is to think about ways that they might be able to use tools to better monitor the information environments that their patients are encountering. Some of this can happen online in terms of actually scraping and monitoring what's out there in places that many healthcare professionals wouldn't necessarily normally look. It also might be very simple in terms of really having a robust and constantly updated, frequently asked questions section on your website, or thinking about the ways that you gather questions to answer for your patients. And so it may well be an organization level response as well as an individual clinician response.
So it sounds like the goal should not be to convince the patient that what they believe is wrong.
Yes, I think that's really a succinct way of putting it, because there's probably not time, frankly, in a quick exchange. And instead, if you can see the patient, if you can acknowledge them in some way, that might help. And if you can also celebrate that conversation as a victory in and of itself, I think that's also crucial. So there's an opportunity for you to potentially redirect them to more credible information. But there's also something there to celebrate, which is that that patient has brought something to your attention, which means that they trusted you enough to talk to you about it, which means that they aren't off on their own, unbeknownst to you, searching on the internet and just not connected with the healthcare system at all. So actually, we view those challenging conversations as real opportunities for celebration in a way, because it means at least there's a basic relationship of trust between the patient and their clinician that ought to be nurtured and could be maintained. It would probably be worse, the situation in which you feel like you've never encountered any of this, because then it may well be that you're just not hearing everything that patients are encountering.
Can you talk to us more about ways to reframe the way of thinking about these encounters so that physicians can avoid coming off as scornful or dismissive? And how can physicians be sensitive to cultural factors like race, ethnicity, and religion when dealing with patients who are misinformed?
Right. So I think, generally speaking, we're all human, right? And so it's difficult sometimes to hide our reaction to information or misinformation that we might hear. But if you keep in mind an orientation, just as one would typically in terms of trying to figure out what was going on medically with somebody, the real key here is listening. And the real key is trying to listen and to not necessarily jump in right away with ideas. And so that turns out to be important. Humility also turns out to be important in terms of not overstating one's own certainty. That can be difficult sometimes, again, if you only have a limited time for an exchange. But generally speaking, I think one important principle to keep in mind is that the patient hasn't come in to try to offend you necessarily or to insult your intelligence, and to essentially try not to take it personally. That they may well, again, if this is an opportunity, it means that they have brought this into you, they're attempting to consult with you as an expert. They might be excited about or have found a lot of information. But again, sort of realizing that it doesn't do anybody any good to necessarily win the momentary argument if people walk out feeling like they aren't going to necessarily trust or feel comfortable raising something again in the future. So it really is a matter of trying to have some patience and compassion in ways that we have so many examples and so much evidence of clinicians doing that and so many other aspects of their everyday care for patients. So the same way that you might think about engagement with somebody around a diagnosis or around other aspects of their life that are challenging, we might also extend into this, because on some level, if somebody is bringing misinformation, it's a problem and it's another opportunity for you to work with and to help the patient. So if you bring the same kind of attitude that you would if they had an earache to something that they printed off the internet, that might help.
And what about those cultural factors like race, ethnicity, and religion?
Yeah. So one of the most important realizations that we've had in terms of thinking about the problem or dilemma of misinformation is that the remedy seems to be rooted in trust, which might seem like a bit of a leap. But I think ultimately what we need is not to necessarily vanquish all sorts of misinformation from all corners of the internet, but rather to get people into trusted relationships with healthcare organizations where they're having informed discussion about this. So there's partnership. Well, that requires relationship building over time. And so, as we think about a dramatic situation where you've got a new pandemic, for example, or a new concern, that's not the time to necessarily just shift right away towards trying to spread information to people. You had to have been building that relationship over time. So I think part of the challenge that we have right now are longstanding concerns, health equity, but also relationships between people and communities and the healthcare organizations that serve them or haven't served them well enough over time. And so I think part of the work that we can be doing when it comes to some of the factors that you just raised is to build now for the next pandemic, build now for the next set of challenges down the line, and to do a better job of trying to make sure that not only are various communities represented in leadership in the different healthcare organizations, that patient voices are a part of discussion. Those things go a long way, not only in terms of other types of planning, but also when it comes to the kind of trust that's necessary for these kind of really challenging conversations. It takes a lot of trust to raise something with somebody that you don't know if it's right or not, and to also trust that they're not going to necessarily be dismissive of you. And so you think about the kind of respect and trust that's necessary. It takes a lot of work to build that into relationships, and it's easy to have that go away. Every time you have a trust building exercise or conversation, realize that you're really making an investment for the future.
Okay, Brian, I am going to give you a couple scenarios.
Okay.
So pretend I'm the patient and you are the physician.
Okay.
And I'd love to hear how you would deal with these scenarios with the teachings you've been telling us about today. Okay. So I am an older patient and I have type 2 diabetes. And I have read online that cinnamon is good for diabetes. So I'm going to take cinnamon pills and I'm going to stop taking my diabetes medications.
Yeah. So there's a lot that could be offered here in terms of advice. The first thing I want to just offer is a really important caveat. I'm not trained as a medical professional, but what I would offer to somebody who is in that situation is the advice along the following lines. So in that situation, you are pointing out a potential remedy that you found that seems to be more attractive to you than the course of treatment that you were on. I'm curious to know, what is it about the cinnamon pills? What is it that's attractive to you about that? Is it a matter of cost or convenience, or what is it that seems to be better for you in that regard? And perhaps then you'd have an answer to that. But that might give a chance of actually understanding, are we really talking about somebody who's desperate for something that is different, more available, differently priced, potentially more efficacious, not going to have the same side effects? And then based on what you raise there, I might be able to point out alternate possibilities within the realm of what I think would be medically appropriate. Or I could point out certain aspects of how the current treatment actually isn't as sort of far off from what people think, or maybe there's different ways to adjust that. So that might be one direction we could go with a conversation like that.
Okay. Now let's do a COVID one.
Okay.
So clinicians are hearing from some patients that COVID-19 has been blown out of proportion and that masks aren't helpful. So how would you advise a physician to respond to a patient that says this? And is it harder when the misinformation comes from the President of the United States?
It's really important, I think, with an infectious disease, that's facing society, to realize that you're behaving not only for yourself, but also for your loved ones and for those that are around you. And that's sometimes you think about the ways in which some of your behavior doesn't just affect you, but it also affects other people. And so that's something I think is really important to point out here. There does seem to be a really important cost-benefit ratio when it comes to something like a mask, where we know that it does reduce the amount of potential contagion that you're spreading back out into the environment. And if everybody did that, we'd be in a much better shape. So it's possible that we could reframe or think about some of these recommendations. If we assume for a moment that everybody's trying to get us to a spot of being better and healthier, and to realize that there's not necessarily an underlying agenda, that there seems to be good reasons why that global recommendation, has been out there to wear masks. That's worth keeping in mind. And so I guess that's something that I'd try to emphasize, is the importance of community protection, and to realize that not all of what's been pronounced politically has been carefully medically informed, and that we're all still learning here. And science works in a way that sometimes we change our minds a bit with new evidence. And so we're really at an early stage where we're trying to figure out what the right answers are. But there seems to be really good evidence in support of community protective behavior.
A lot of the principles you're talking about, it's funny, they remind me sort of just healthy interpersonal communication.
Yes.
Listening, empathy, compassion. These are tricks that you'd probably hear about if you did couples counseling.
There's a lot to be said for that. And yet, why doesn't that happen? Well, I think that in a clinical context, like in many interpersonal contexts, there's a lot of additional stress in a moment where there are not only time constraints, clinicians are busy, but there also is this overarching sense of emotion and stress in the environment. And so I think people have lost sight of the fact that at the end of the day, we've got human beings interacting with one another. And it's important that we continue to see each other in those ways. And I think that that has the potential to go pretty far. And so that's something that we're hopeful that people are going to be able to take a breath, be more compassionate to one another, and to realize that part of the way through this is to not have all the answers, even when what your patient's raising seems pretty outlandish, but to realize that listening to them for a moment might save you a step or two down the line and might be better for all of us together.
So how has your training been received by clinicians?
So something that we've been very excited about has been the fact that these ideas are straightforward, they're common sense, and yet, if you think about what we're asking people to do, it generates additional ideas. So not only is there a way through some of the difficult conversations that people might have, but it also gives ideas for what healthcare organizations themselves might go off and do. So we've had a couple of just anecdotal examples here. One of the people who participated with us earlier this year noted that in her mind, actually, one of the most important uses of our information in the week or so afterwards was an exchange that she was able to have with a fellow colleague. This was not a patient, but rather actually another medical colleague who themselves was actually espousing something that seemed to be problematic. And so thinking about how that conversation might happen, that was really eye-opening and interesting. We also have heard anecdotally an example of a situation where a particular clinic is thinking about developing a tool to help people when they're searching for information online, to then point them to parallel information that's related to their clinic or that's related to their healthcare system. And so people are getting innovative and taking some of these principles and ideas of kind of working alongside patients, helping them navigate their environment. And that's potentially also inspiring new technology developments and new innovation and new strategies. And so we don't have all the answers with our recommendations, but we are hopeful that with this kind of shift in perspective, or maybe reinforcement of a perspective that people realize is really important, that we might get somewhere that's a little bit less polarized and that's a little bit more embracing of patient perspectives.
Do we need more research on this for clinicians?
Yeah, I think that there are a couple of aspects that are going to be important. We've got to find out how easy it is to implement some of what we're talking about in a crowded and difficult and time-limited clinical environment. We can talk about this great conversation you might have, but if you only got 7 or 8 minutes to talk to somebody, that's going to be important to be focused at the very least. So we can use more evaluation evidence, I think, of potential efficacy down the line. It's also the case that we need to find out in a more systematic way about people around the country, clinicians around the country, what their experiences have been. This is a topic that a lot of people have an opinion about, but that we don't have as much formal research on. This has been true across the board as we think about the whole arena of medical misinformation generally. There has been some focus on tracking and tracing what's out there from a content analysis standpoint. We have a little bit less in terms of what seems to work in terms of intervention. There have been some things that have happened in the laboratory, carefully controlled social science laboratory. But I think we need more work to figure out what can be done to produce scalable, widely implementable interventions that we could all work on together.
So for those physicians who are listening, is your training available to them?
Yes, we'd be happy to talk about possibilities for collaboration. You can find me online very easily. You could also email my colleague, Jamie Wood at Duke University as well. We think that there are ideas that ought to see the light of day and that we'd love to be in partnership to talk about. So that would be great.
You mentioned in your email that you're scaling up the program to make it available, it sounded like maybe online?
Yes. So we are going to be offering this in a sort of case-by-case basis as a virtual workshop. And so we're working with folks in the Duke Center for Healthcare Quality and Safety to make this widely available. And so we're early 2021. Hopefully we'll be at a point where people could just click in and be off and running. Up till now, we've been working in more a case-by-case basis to get people registered and through in this new and hopefully exciting endeavor. We originally were talking about doing a lot of this training in a face-to-face manner. The pandemic has changed a lot of that, but something really important that we've realized along the way is that by offering this virtually, we may actually end up being able to have wider reach to work in rural communities, to work in communities that have had economic challenges in different ways. And that's something that's very exciting. We're doing some work, for example, in Rockingham County, which is a rural county up near the Virginia-North Carolina border. And I'm not sure that pre-pandemic, maybe it would have been more difficult to get up there and do that in person. And so doing something like that virtually offers all kinds of possibilities as we think about the future of telemedicine, the future of telehealth, and maybe the future of training virtually as well.
Absolutely. All right, Brian. Well, thank you so much.
Great.
That's it for this episode of JAMA Medical News. I'm Jennifer Abbasi. Thanks to my guest, Dr. Brian Southwell of RTI International and Duke University. Our audio editor was Jesse McQuarters. For more of our podcasts, visit jamanetworkaudio.com.